All right, good afternoon. I'll be giving a talk which was initially going to be given by Dr. Yu, so bear with me here. All right, so we're talking about abdominal imaging in general here. So we'll start with talking about plain radiographs, x-rays, and you guys may be familiar with these. We call them KUBs colloquially. Now, what are some of the things we can see on here? Well, for one thing, in plain radiography, the contrast resolution is limited, meaning you can't differentiate different soft tissues very well. What we can see is, things that are black, like gas. Air will be black, or what we call radiolucent. You'll have then more intermediate shades of gray will be fat, which will be slightly more lucent or slightly less. Slightly more gray sort of than soft tissue or fluid, which will be whiter or more dense on an x-ray. And then completely, very bright white are things like calcium, bones, metal, foreign bodies, provided that they're metallic or radio dense. Another limitation of plain x-rays is superimposition, because you're taking a 3D structure like the body and flattening it into one 2D image. So things that are in the same plane, anterior to posterior, will be squished, and you won't be able to tell what's more anterior or what's posterior on an AP radiograph, for instance. All right. So what are some things that they're useful for? Well, it's useful in things like bowel obstruction or ileus. If you want to look for pneumoperitoneum, particularly if you're looking for large volume pneumoperitoneum or free air in the abdomen, the KUB or abdominal radiograph is useful. Or to look for radiographic foreign bodies. Now, occasionally you can also see gallstones if gallstones are calcified, which is not always, but sometimes they are, and then you can see them on the x-ray. Same thing for kidney stones. You can pick up a lot of kidney stones on x-rays because they tend to be calcified. And remember, calcification, stones, dense things like that will show up as bright on an x-ray. All right, so situations where they may not be as sensitive, just general abdominal pain. You may, unless you're finding one of the things we mentioned before, like obstruction, ileus, free air. Aside from that, limited utility of a plain X-ray. Stones, as you mentioned, gallstones are not often calcified, but when they are, you'll see them, but not very sensitive on an X-ray. And again, soft tissue abnormalities, going back to the general abdominal pain perspective here. A lot of times we're looking for inflammatory soft tissue processes like appendicitis, diverticulitis, cholecystitis, pancreatitis, all those itises. Those are going to be you're not going to see those on a plain radiograph, so low yield for those. All right, so a few examples here. I'll let you guys take a look at these for a second and see if you get an impression of what you think is going on. I'll point out a few things. Yes, so what we see here, we have two radiographs. We have a supine frontal radiograph and presumably an upright radiograph. And what we see on the supine radiograph is this sort of, well, first thing that we see here is this what we call a wriggler sign, which is when you see both sides of the bowel wall outlined with air on each side. And so that's what we're seeing here, this thin white stripe, and that's a sign of pneumoperitoneum or free air in the abdomen. And the second thing, which is more sort of, it's more of a qualitative finding, is this sort of, to me, this looks generalized, sort of more lucent or more grayish black than it should be. And that's telling me that there's probably some air superimposed over all of this, which is making it more lucent. And then on the upright radiograph, you can see more obviously and with more certainty that there is a gross amount of free air underneath the diaphragm. Here's the diaphragm, and then below that you have all this free air, and then the liver. So gross pneumoperitoneum or free air. All right, so this is sort of a laundry list of some of the causes of pneumoperitoneum or free air, and I think going down to these two here are probably what we see the most of on a day-to-day basis, post-operative mainly, whereas within essentially usually just part of the normal post-operative appearance. Anytime you cut open someone's belly, you're going to have some free air left behind, and peritoneal dialysis, people who are on peritoneal dialysis, air will come in through the catheter while they're, putting in the dialysate, things like that. And then sort of the classic, perforated viscous, peptic ulcer disease, these kind of things, air in the abdomen can either, if it's not iatrogenic, meaning, from something that we've done, it comes either from the bowel or, so it has to come from within the bowel, meaning the bowel has to perforate. And that's most common cause of that, peptic ulcer disease, like gastric duodenal ulcers, a lot more rare these days in the PPI, proton pump inhibitor era. There's also ischemic bowel. Any of these, inflammatory conditions can, in their extreme, lead to perforation of the bowel and therefore pneumoperitoneum. So, but I'll just emphasize, by and large, this is what we're going to see on a day-to-day basis. All right, I'll again give you guys a few seconds to look at this and gather your thoughts. All right, so I hear some mutterings of, what, so again, you have this wriggler sign. You can see this is just one example. There's numerous examples of this throughout this image, but here's one example where you see gas outlining both sides of the bowel wall here. So this is a guy with pneumoperitoneum. Also, this is one of those cases where you can see the gallstones. A lot of times they'll be hexagonal shaped, or sort of, they have these geometric sort of shapes to them a lot of times. And a lot of times centrally they may even have gas in them. So these are classic gallstones in the, and this is what we'll see in the right upper quadrant. Here's the liver up here, so gallbladder's probably hanging down like that, and there are stones in the fundus. He also has the Dobhoff tube, incidentally, which is in probably second to third portion of the duodenum, satisfactory position. All right. And this is just a lateral view showing, I'll let you guys take a look at this too. This is, let's say this is the same patient. This is actually, we're cheating a little bit, this is actually a scout radiograph from a CT scan, but it doubles as a lateral view here, so. I'll just focus your attention on this area. Yeah, this is, I don't know how well it's projecting there, but you can see clearly there's free air, which has risen into the non-dependent or portions of the abdomen, and you can clearly see, the free air here much more obviously. So these are situations where if you're concerned for free air and you're ordering KUB, go ahead and order the decubitus view or the lateral view, and then that can be helpful. All right, here's another KUB. We'll give you guys a chance to take a look. And then there's a companion decubitus view. So this is a left side down or left lateral decubitus view. You can see the right marker is on the non-dependent side. We'll go back here. So this is a little bit more, I guess, subtle. There's, in the right upper quadrant, there's some lucency here, which doesn't look like air within bowel, right? And then if we go to the lateral, or the decubitus view rather, yeah, it's kind of in the corner of the film, but look up there. There's some free air which has risen to the non-dependent portions of the abdomen, and you can see that there. Less obvious. All right, I'll let you guys take a look at these two frontal views of the abdomen. I believe this is upright, this is supine, same patient. All right, so what we see here, we'll start with the supine view actually here. So, we see these tubular air-filled structures, right? These are bowel loops. This is small bowel, I'm just saying based on the central location. And to me, this pattern of the folds here is more that of small bowel. So these are dilated small bowel loops. We allow typically up to 3 centimeters or so caliber small bowel before we say, okay, this is frankly dilated, you know. Without a ruler, I can look at these and tell you these look dilated. And anytime you have dilated small bowel, you're concerned for either an obstruction or an ileus. And one thing, you know, if you see these air fluid levels on the upright view, not entirely specific, but suggestive of maybe an obstruction. Typically, you like to see more of a differential air fluid levels, where you have, like, maybe you'll have one fluid level here, a different level higher up here, or lower down, you know, something. But that can be suggestive of obstruction as well. So let's continue on. So that was a case of a small bowel obstruction, and this is just again a mini laundry list of some of the causes of obstruction. I think far and away adhesions are going to be 90-95% of your obstructions right there, adhesions, followed by hernias. A lot of people have ventral abdominal wall hernias, either umbilical hernias or post-surgical incisional hernias. And so bowel loops will get caught in those, and then they'll cause obstructions. Strictures, those are not uncommon as well. And if you have a stricture in the small bowel, typically it's related to some sort of prior inflammatory process, whether that's inflammatory bowel disease, radiation therapy. You'll see this in cervical cancer patients a lot. They get a lot of pelvic radiation, so their pelvic small bowel loops will end up getting strictures and stuff. And it is possible as well, if somebody has a ischemic insult to the small bowel, they may ultimately go on to stricture that segment. But by and large, you're going to have strictures from inflammatory bowel disease, Crohn's, that kind of thing, or from prior radiation therapy. Another thing you'll see strictures or obstructions from is tumor. Patients who have, this is most commonly in patients who have peritoneal carcinomatosis from either pancreatic cancer or some other GI cancer, or from a pelvic cancer in women like endometrial or ovarian cancer. They get a lot of times they'll get peritoneal carcinomatosis, where you just get tumor involving your mesentery, and you'll get tumor deposits on the small bowel serosa, and that'll lead to stricturing and extrinsic compression and basically obstructions. And more of a pediatric thing, intussusception. In pediatric patients, you think of ileocolic intussusception as a cause of bowel obstruction. In adults, you can get small bowel intussusceptions, but oftentimes that's going to be related to the presence of an underlying tumor or underlying mass, which has caused an intussusception. And just for those who may not be familiar with what intussusception is, it's when the bowel is like, think of it as like a flexible tube, and if part of that telescopes into the either the more proximal part of it, then that's what we call an intussusception. And volvulus, again, more of a pediatric thing. Patients who have malrotation of the gut, and then undergo volvulus. And then finally, more kind of a unique and arcane one, gallstone ileus, or basically patients who sometimes will pass a gallstone from the gallbladder through the common bowel duct into the bowel, and then that can go into the small bowel, and actually, if it's big enough, cause an obstruction. All right. So I'll let you guys, now we're going to move into the more CT sort of oriented section of this talk, okay? So I'll give you guys a few seconds to look at this. And so we have a coronal contrast enhanced CT of the abdomen and the axial cross section as well. So take a look. All right, so you don't need to kill too much time on this one. A lot of small bowel loops that are dilated here. And so this would be consistent with a small bowel obstruction. And in this case, I can say on these images that this is most likely an obstruction, not an ileus, because I also see right here some decompressed bowel loops, which I can assume are going to be distal to these more dilated ones. So if I know that I have dilated small bowel loops on one end and decompressed loops on the other end, there has to be an obstruction somewhere in between, right? So. And another area where CT is helpful in small bowel obstructions is, to find the underlying cause. Again, mostly it'll be adhesions, and what you'll see there, you may not actually see, you'll just see the bowel come to you'll see the sort of bird's beak appearance right at the transition point. But if there's like an obstructing mass or something of that nature, you could hopefully see that with CT. So And then another thing is to look for complications of the obstruction, meaning do they have bowel ischemia? If you're looking for, we'll get to some of that later too, though. Let's not get ahead of ourselves. Okay, so, well, unfortunately, he kind of gave us the answer here, but this is a acute case. You can see this patient has dilated small bowel loops consistent with underlying obstruction, and if you follow it far enough, we have a nice little gallstone there. And this is, although it's called gallstone ileus, it's probably more appropriately called gallstone obstruction because it's not really an ileus, it's obstructed. So, I don't know who named it, but. All right, so I'll let you guys take a look at this for a sec and gather your thoughts. So the bladder, let's say this patient had a contrast-enhanced CT a few hours prior. So the bladder is just filled with contrast from their CT scan. Remember, the contrast is excreted by the kidneys and therefore into the bladder. So. Let me see what's next here. Here's, all right, look at this one now. What is happening here? Okay, let's talk about this one. This is another acute case here. Okay, so what's most impressive here, I'm going to assume it's impressive to you as it is to me, is this guy, right? So we have this large distended segment of presumably bowel, and kind of looks like it's coming out of the pelvis, right? Kind of coming out of the pelvis and, extending up into the right upper quadrant here. And incidentally, patient's probably been shot before. Let's see. Let's go to the next slide here. Okay, this is different patient, same disease. Take a look. Oh, actually, sorry, same patient. He has the same, yeah. He's been shot too, so it's probably the same patient. Yeah. So same patient. Okay, so, whoops, so let's just stop here. Okay, so let's keep going. Well, yeah, okay, this is good. This is the same patient. This is now his CT scan. So he had this is his gout film from the CT scan. So basically, same findings as before, but way more impressive. And then on the CT, we kind of, let me talk you guys through this here, but this is a patient who has a sigmoid volvulus. So going back to the radiograph, this is a very classic appearance of sigmoid volvulus. Where you sort of have this, well, this is the sigmoid colon severely dilated, and it gets so dilated that it rises out of the pelvis and into the right upper quadrant, just out of pure mass effect. Same thing, and then sometimes it's been likened to a kidney bean shape. It looks, kind of kidney bean shaped, I guess, yeah. So whenever you see this sort of diffuse, this significantly dilated kidney bean shaped thing coming out of the pelvis, going to the right upper quadrant, you should think about sigmoid volvulus. And that's what we're seeing on the CT here. This is the actual point where the sigmoid colon has twisted around itself, basically. And when that happens, it sort of obstructs the inflow and outflow. And so then this bacteria start forming all this gas and stuff, and that gas has nowhere to go. So the bowel just distends and rises up into the right upper quadrant. So that, so here we go, sigmoid volvulus. Typically, these are elderly, immobilized, debilitated patients. And then in younger or more middle-aged patients, you'll see something called cecal volvulus, which we'll see here in just a second. So look at this radiograph for a second. So basically, nothing. There's a huge dilated segment of colon here, and this time it's more towards the left upper quadrant as opposed to the right. But and then same thing here. See this? We've done it looks like we've done a barium enema here, a retrograde injection or contrast into the rectum, and again, you see this area not filling with contrast. And it looks like he subsequently, well, let's come back to that. So this is a case of cecal volvulus. So cecal volvulus oftentimes has that sort of, similar to sigmoid volvulus, we'll see this large distended segment of colon, except that it tends to flip more either into the upper abdomen in general or towards the left upper quadrant sometimes. So that's just, how it, so then the cecum is typically in the right lower quadrant. Now when you have cecal volvulus, once it volvulizes, it tends to flip up into the upper abdomen, which is what's happened here. And then similar to sigmoid volvulus, the inflow outflow are obstructed, and so you get a lot of gas building up, and it distends. Let me see what we're showing here. Okay, this is subtle case. Okay, so I'll let you look at this KUB for a second here. So what do we see? Well, not a whole lot, except for this here. This is black like gas, and it's in the upper abdomen where it shouldn't be. So is it pneumoperitoneum, or is it not a really classic look for pneumoperitoneum? So we do. If you look at the CT, he actually has gas in the retroperitoneum tracking around the kidney. So when you see retroperitoneal gas, you have to think of, well, let's see what parts of the bowel go retroperitoneally. Well, parts of the duodenum and parts of the colon can enter retroperitoneal. And so if you have gas in the retroperitoneum, those are possible sources. So let's do another we have a KUB on this is actually a pediatric patient. You can see the growth plate hasn't fused here. So take a look at this for a sec. So let's say this is a critically ill baby in the ICU, in the NICU. One thing they're always looking for is NEC, or necrotizing enterocolitis, and one of the plain film findings is pneumatosis, or gas within the wall of the bowel, and that's what you're seeing here in this area, in this right lower quadrant right here. You see this sort of mottled appearance, this almost, and then this all along this wall here, you have air within the bowel wall itself. And you kind of can get that feeling as you see, as you look at that for a second. This is pneumatosis. And this is CT showing, again, pneumatosis. This is air within the wall of the bowel where it shouldn't be. Another example here. And in this case, there's actually been perforation and there's free air, which is obviously a little more of a, which is a concerning finding because that implies that this has gone on to rupture. So what are some causes of pneumatosis? We've seen several cases now, but causes, well, we mentioned one in the neonatal type patient, in necrotizing enterocolitis. In adult patients, typically you're thinking more of ischemic bowel. Patients who have a mesenteric ischemia, and also there are benign sort of incidental causes. Patients can get it after colonoscopy. Sometimes they'll just develop pneumatosis, and it's not a need to go and operate or anything. And even sometimes people with coughing fits, things like that, for whatever reason, sometimes it just happens. We don't really know why, but they're asymptomatic often. All right, another radiograph here. Let's take a look at that for a sec. Let me see what's next. Oh, I see what the definition. Well, this is not projecting very well, but I'll draw your attention to the right upper quadrant here. I don't know if you can see this or not, but there's these branching sort of loosened areas in the liver, right? So that's another very subtle plain film finding, which becomes much more apparent on CT. You have all these branching lucencies, mostly in the left lobe. And what we're seeing here is portal venous gas. So remember, air is black on CT. And the only thing that branches like this in the liver is portal vein. And biliary, it could be biliary too, but usually the biliary tree isn't quite so branching as, all these tiny little, so this is portal venous gas. And what does that mean? Why is that concerning? Well, how does gas get into the portal venous system? It means that the bowel is necrosing or dying often. So we have bowel necrosis, ischemia. This can be a secondary sign that, this patient is in dire straits. So there we go. Here's another example. Now you'll see this mostly in the left lobe. Why is that? Because the left lobe is non-dependent. Remember, gas is going to rise, so it'll fill up the left lobe before it starts to work its way down. All right, this is a cute case. All right, take a look at this for a second. What do you guys think of this? Here's a CT. Take a look. So I'll just orient you: gallbladder, liver. So this is black air within the wall of the gallbladder. And there's also what we call fat. This is what we call fat stranding here. When you have this is normal, clean, dark fat. This is inflamed fat. This is fat with edema, with inflammation. So we call that fatty stranding. That's one of our signs that something's happening there. Something is causing this fat to be inflamed. And in this case, it's the gallbladder. It's distended. This is the gallbladder distended. There's what we call pericholecystic inflammatory changes and air in the gallbladder walls. This is emphysematous cholecystitis. So a sign of a very severe cholecystitis. The gallbladder has already is so infected that the gallbladder wall is already dying and necrosing. All right, next case. I'll let you guys take a look at this for a sec. So just to orient you, we're in the pelvis here. This is a section of sigmoid colon here, and this is the abnormality with an arrow on it. So it's maybe a little tough to appreciate on a single slice without being able to scroll through the images, but look at this section of sigmoid colon. You have these tiny little outpouchings of gas. So these are diverticulae. The patient has sigmoid diverticulosis, okay. Secondly, look at the fat around the colon. Looks inflamed. This is the same fatty stranding that we saw earlier, now surrounding the sigmoid colon. So not only do they have diverticulosis, they have diverticulitis. Not only that, they now have a pericolonic or fluid collection in their fluid level. So they have a diverticular abscess as well. So this is basically an example of diverticulosis, which has now been, or diverticulitis, which has been complicated by abscess formation now. So here we go. And assuming this is the same patient, it has been further complicated by, I'll let you guys decide what to make of this real quick. So this is the liver, and within the right hepatic lobe, we have a hypodense fluid collection with a thick rim, and this is a liver abscess. So the patient, one of the complications of any intra-abdominal infection is the formation of liver abscess, because the bacteria work their way into the portal venous system, and then from there they can set up shop in the liver and you get abscess formation. Or biliary tree infection, somebody has cholecystitis, cholangitis, that can lead to abscess formation in the liver as well, because the bacteria ascend through the biliary tract into the liver. So liver abscess. All right, acute case. All right, take a look. This is a coronal CT section. This is the inferior edge of the liver, so we're looking in the right lower quadrant. So we have a dilated tubular structure in the right lower quadrant. Here's the cecum. This is the ileocecal valve. You can see it here. So yep, we have appendicitis here. This is a dilated, inflamed appendix. The wall is enhancing. It's probably, I think we use 6 millimeters or so as the upper limits of normal. Yeah, I don't like to use numbers too much, but this looks inflamed and dilated. And on top of that, the icing on the cake, you have this appendicolith or fecalith, this sort of calcification near the appendiceal orifice, presumably obstructing it and resulting in the appendicitis. So just a quick note, you can sometimes see appendicoliths in asymptomatic patients. So just because you see an appendicolith doesn't mean that the patient will therefore have to have appendicitis. So as long as the appendix itself looks normal, the appendicolith may just be incidental. So, but in this case, acute appendicitis until, and once you see appendicitis, you want to look for, any downstream complications such as phlegma and abscess. In this case, don't really see a whole lot of that. There's no fluid collections or anything around the appendix. The enhancement is very uniform, no signs of perforation. This looks uncomplicated appendicitis. So we just took a tour of some of these itises of the abdomen. Appendicitis we just saw. We didn't show you pancreatitis. You saw diverticulitis, cholecystitis. And this is just a cute little graphic kind of showing, the differential diagnosis for abdominal pain in the different quadrants. One thing that is interesting to note here is you can occasionally see on a plain radiograph something called a sentinel loop sign. What is that? Well, when you have an inflammatory process in the abdomen, the bowel in that area, in the inflamed area, will sometimes not peristalsis well. It'll go into a sort of focal ileus, and so you get a focal dilated loop of bowel, which can be called a sentinel loop. And so let's say you see a sentinel loop in the right lower quadrant, then you could say, oh, well, maybe this patient has appendicitis, who knows, or some sort of inflammatory process in the right lower quadrant. So, and then if you have pancreatitis, oftentimes you'll see that happen in the left upper quadrant. So this could be a patient with pancreatitis. Could be, who knows. And here's just some more examples of fat stranding. Right here you can see this is probably an appendix. This is the right pericolor gutter. Common place to see a retrocecal appendix sometimes, so this could be an appendicitis. But look at the fat around it. Compare that with the cleaner subcutaneous fat. This is what nice, normal, healthy fat looks like. This is inflamed fat. around that appendix. Same thing, diverticulitis here. You have a section of sigmoid colon, multiple diverticulae, and the fat. Look at the fat around it. So it's very gray as opposed to being black, you know. So this is fat stranding. A sign of, in this case, diverticulitis. All right, and then this is this image is showing what free pelvic fluid looks like. In this case, it's right here. Tough to tell on this image without being able to scroll through it. Basically, what you're looking for, you know, fluid is going to be, you know, a gray-looking structure. Typically, if you draw a ROI and you measure what we call the Hounsfield units, which is a measure of the density of the fluid, you'll get between 0 to 20 for simple fluid. And kind of a nonspecific sign that goes along with any inflammatory process. It'll lead to edema and free fluid, and so it can be a sign to look a little bit more closely and find the issue. And then I'll let you guys take a look at this for a second and see what you guys think is happening. So if you look at this, this is a transverse section, axial section through the upper abdomen. You see a liver here, kidneys, top of the kidneys. This is the pancreas. And if you look at the fat around the pancreas, look at this here. There's some fatty stranding around the pancreas. So this is a pancreatitis. And then at the tail, you have this fluid collection. So this is an example of pancreatitis complicated by this fluid collection, which if it's old enough, you can call a pseudocyst. So. All right, we've seen this one before. I don't know, this is duplicated. All right, on to the last bit here. Okay, what do we see here, guys? Yeah, this guy has staples. He's had surgery. And whoopsie daisy. Yeah, so we have some. Yeah, so this is the radiopaque marker on a lap sponge here. So, or multiple ones in this case. Now, granted, maybe they're planning to go back anyway and take them out, so no big deal. So, same thing. You have this curvilinear, you know, radiopaque structure. This is what lap sponges look like, and this is just showing. This is what gives you that radiopacity there, that line. Okay, so this time we see something similar, but next to it we see this giant, you know, blob of, you know, heterogeneous-looking stuff. Yeah. So, same thing, lap sponge. This is the radiopaque part, and this just happens to be, you know. All right, on CT, how's it look on CT? Well, kind of the same. You have this radiopaque marker, and then this sort of mottled stuff is the sponge itself. Now, one thing, there's sometimes if these are left behind, the people will develop an abscess around it. Their body will wall it off and form an abscess, and that's called a gossypyboma. That's probably what this is here. Look, you have this nice, the body has built a wall around it and contained it. So, gossypyboma. All right, on to some other stuff now. Some mimics. You know, you might see these mottled looking things and be, oh my God, what's that? It's not in bowel. Is it some sort of fluid collection? No, patient had surgery. They put Surgisil behind. That's what that is. Surgisil has this sort of mottled looking appearance to it. So used in surgery for hemostasis, and not to be confused with retained foreign bodies or free air fluid, whatever. Same thing, this is a gel foam sponge, again, more surgical hemostatic material. Has a similar sort of look to this, to the Surgisil, looks fairly similar.